Hello, my name is Jose Maria Torres Bravo. I will talk about lower extremity functional screen for biomechanical faults in female athletes. Definition: participation in athletic continues to screen in frequency among female in all age groups. This screen has present a disparity between male and female athletes, with females suffer a significantly higher overall injury rate from sport exposure. The greatest proportion of sport injuries occurs in the lower extremities, and a relationship has been established between lower extremity muscle deficits and increased injury rates.
In January 2011, Dr. Lee Cohen, Philadelphia sports podiatrist and podiatric consultant to the Philadelphia Eagles, Sixers, and Wings, conducted a workshop for the Eastern Athletic Trainers Association on biomechanical explanations for selective sports injuries of the lower extremity. The event took place at the Lowe's Philadelphia Hotel and proved to be an informative session.
We're going to do injuries that you see every day, and I'm going to give you the biomechanical explanation for those injuries.
Dr. Cohen discussed various strategies for determining the nature and extent of lower extremity problems in athletes, including the use of the Cohen Index as a diagnostic tool. The workshop reflected Dr. Cohen's extensive hands-on experience in the field.
The problem foot that I see most of my life is where we see the arch, the rear foot arch is elevated, the numbers are high, cavus rear foot, and a pronated forefoot.
Demonstrations of podiatric diagnostic procedures were also included, using the athletic trainers in the audience as subjects.
There's going to be two things about an inverted forefoot. It's going to be either fixed, which is everyone calls the forefoot varus. You actually adduct that left foot too.
It changes foot position from your first to stand.
Look at the toe grab.
A demonstration of the creation of molds for custom orthotic insoles was also provided.
It's amazing. It's amazing what they do.
The members of the Eastern Athletic Trainers Association who attended this workshop got pointers from one of the best, sports podiatrist Dr. Lee Cohen.
Injuries resulting from sport participation have been extensively investigated in an attempt to identify causative factors. Lower extremity injuries account for the largest proportion of injuries resulting from sport participation. The traditional pre-participation medical examination lacks a performance assessment to determine athletic readiness. Manual dynamometry was used to assess jet strength. The modified star excursion balance test was used to assess single leg balance. The lower extremity functional test was developed based on clinical experience and include the following tasks: two-legged squat, two-legged hot, one squat, one-legged, and one hot. The graded task was scored on a scale of 0 to 3. Component scores were submitted for a total possible score of 21 points, with a higher score suggesting better leg mechanics and lower risks of injury.
I started dancing when I was really young. From dancing, I went to cheerleading. I've been playing field hockey since I was in 6th grade and soccer since I was a freshman. I like being competitive and winning. So I was a cheerleader and I had a competition. I was doing my routine and I jumped and I landed wrong. My knees went in towards each other and I just felt a pop, then I fell.
By the time I got there, they were about to put her on the stretcher and take her to the hospital.
And then I got an MRI, and they told me that I tore my ACL. I hated being injured, not being able to play, so I just wanted to get back on the field and play again.
Specifically when you're dealing with high school and junior high school age athletes, and the ultimate goal is to get them not just back on the field, but also get them back to the level of play that they had prior to their injury.
I knew that Cameron was going to be in good hands.
She did everything we asked of her in the beginning. She iced when she was supposed to. She took her anti-inflammatory. She did her home exercises.
They pushed me to do my best because they know what I can do. And if I was like slacking one day or say, then they would be like, I know you can do better.
So what we've noticed in the past several decades, there's been a tremendous increase in the amount of athletic participation of female athletes. And with that, we've noticed a significant rise in ACL tears.
When a girl lands from a jump, her knees tend to come in towards each other versus staying out nice and wide over her toes, which has to do with weakness at her hips.
And a lot of the research that we do is focusing not just on treatment of ACL injuries, but also on prevention.
I only see one patient an hour, so here at Nemours, I can spend that entire hour with that patient. To really be kind of picky about how they do their exercises on their form.
The staff here, they want to see you do better and do better the right way. And I feel like I do anything now. Like I can jump higher. This season coming up, when I'll be stretching a lot and doing more activities.
I regularly meet with the therapists and trainers, just informally and formally, just to kind of go over patients, just to see how everybody's doing.
I like the team because they cared about Cameron and they were actually hard on her to make sure that she was doing what she was doing, not just during the sessions here, but also when at home.
I'm strong and I'll continue to get stronger and stronger. So now I just go hard every day.
Application in physical therapy. The fundamental role of physiotherapy in athletics or in any other sport is the prevention of injuries, the treatment when they occur, and finally, the readaptation to the specific sport. It is in charge of monitoring the process and evolution. It can also include controlled exercise, manual therapy, massages, bandages, and electrotherapy. The physiotherapist is key to prevent you from getting hurt, and she will provide you with a series of techniques and exercises according to your needs. Issue applied in Ecuador. In the case of Ecuador, in this discipline, there are deficiencies on the part of the trainer in the work, with the functional zones and the adequacy of these for the development of the areas of endurance and sport walking. Pros and cons. Pros: prevention of future ailments and injuries. Physiotherapy works adapts the body to the sport being practiced and strengthens muscle along that line. Cons: in the absence of competition due to injury, it can cause the runner to lose aerobic capacity. It is a sport of high impact on the extremities that can cause knee and ankle injuries.
All right, so for today's video, we're going to be talking through a functional screening examination for the lower extremities, specifically looking at the hip, knee, and foot and ankle, recognizing that really any of the tests and measures that we're about to walk through can be utilized in terms of screening and looking at functional demands of these joints as we move into the lower extremity. Could be used for the hip, could be used for the knee, could be used for the foot and ankle before beginning a more formal joint-specific objective examination. And so recognize that these could all be utilized, or you could use them as more of an a la carte menu, taking that which you think most is applicable based on the comparable sign, the reports of discomfort or pain, or reports of ADL or functional limitations. So let's go ahead and dive in as we look at these specific special tests and measures. To begin with, we're going to look at a totality of willingness to move. And so this begins as the individual walks back to the treatment room. As they enter the clinic, you can begin that visual observational assessment at that very beginning. Part of what goes into that as well is gait. And so we may ask our patient to walk over a defined area several times. As they do that, we can look at that from a sagittal view. We can look at it from a frontal plane view. We can even look at it from a transverse plane view. And things that we're looking at are really head to toe, looking at how they contact the ground, foot, and ankle. Is there an inward or outward variation of foot and ankle, or what we might say too many toes sign? The position of the knee, more genu-varum, more genu-valgum, or even if we're in more of the frontal plane, a degree of genu recurvatum. As we look at the hip, the foot and ankle will tell us a lot about the hip. A lot about in terms of equal stance or weight bearing left to right. Even into the trunk, arm swing, posture, spinal curves. There's a lot of information that we can get from gait, and as we look at our right versus our left side. Additionally, once the individual has completed gait, we can look at several other components, and we're going to begin with a squat. So we're going to have our individual come to kind of the middle of our treatment table here. We'll have them turn about 90 degrees, perfect. And with a squat, we want to ask the individual to squat as they would normally do. There's kind of a couple ways we can look at this. We could ask them to pick up something off the floor, or we can have them perform more of a double limb squat that we may demonstrate. And it's a little bit of an open to interpretation aspect. So sometimes I will place an object on the floor and say, if you had to squat down to pick that up, say it was a basket of laundry or something heavy, how would you demonstrate that? And then we can allow the patient to do that. As they do that, we can visualize what strategies they utilize. If there was any hesitancy or if there was any pattern of movements that may be slightly varied than what we would expect. From there, we can also look at their ability to do a double limb squat repetitiously. So we may ask them to do it 2 to 3 times, looking at fluidity of movement, smoothness, again, is there any hesitancy or fear of movement? And then we can also ask them to do a single leg squat. Now there's some debate among clinicians about how best to demonstrate this. Is it a squat where one leg is fully off the ground? Is it a squat where they're slightly behind so it almost becomes more lunge-like? What many clinicians will do is they'll actually use the table as a guide. So they'll have the patient back up a little bit, provide what we might call a kickstand, where they can use their heel to balance just a little bit, but then their stance limb begins to take the brunt of the weight and the force, and then have them go through a single leg squat just to where their seat touches the table, and then come immediately back up for a total of 3 repetitions. Good. From there, we would have the individual switch sides. So now their right leg is going to become their stance or weight-bearing limb. They get the kickstand or a little bit of assistance on the left side. And we have them go through that again for a period of 3 times. Things that we're looking at are the overall quality of movement, if there's any pain that's reported or reproduced, as well as their ability to control and sequence the motion from a motor control standpoint. From here, we can now look at a couple other tests, such as the single leg stance or a balance assessment. Best to do it on a firm surface, typically unshod outside of shoes or socks, and then have the individual perform it on whichever side they want to start with. And so you say, pick a side, maybe balance on one leg. We're going to hold this for approximately 30 seconds. From here, you can identify whether or not the individual is abducting an arm to help with center of mass and balance, if there's a significant amount of postural sway, if they're having to adjust gaze for gaze stability, if there's a whole bunch of movement kind of down at the foot and ankle, or even gripping of the toes as they look to really hold on to the floor. If you want to increase the challenge, you can also have them close their eyes. And oftentimes what you'll see is as we start to play with some of those other balance systems, you'll increase the postural sway that occurs. You can then have them switch and reproduces on the opposite side. If a concern is a fall risk, ensure you're guarding or doing this next to a sturdy object that allows you to best protect your patient. Next, we can look at some more dynamic activities, things that we might consider to be more plyometric-based when we look at things such as storage and release of energy. And so now we get into some jumping aspects. The first thing that we might look at is a double limb jump, where the individual has to land on both limbs and produce the jump. And we look at that 3 times typically. And so we'll ask our individual to jump 3 times. And information that we're looking for is really whole body at this point. Are they landing symmetrically? Are they taking off symmetrically? Are they shifting their weight one side to the other? Are they able to track correctly, or at least in a fairly straight alignment at the knee? Or do we start to see some asymmetries? In essence, we're asking ourselves, are there any things that we need to be aware of, or are there just some things? Meaning, they're interesting, but they're maybe not contributing to the actual pathology or the complaint that the person is presenting with today. Additionally, just as we did with the squat, starting with double limb and then moving to single limb, we can move to a single limb assessment with this as well. And we typically reference this as pogo jumping. And so we have the individual hop about 10 seconds on each limb. What we're looking for, again, is fluidity of movement, their ability to store and release that energy and force, attenuating force. We ask with regards to how their symptoms may be changing, better, worse, no different. And we see how big the pattern of movement is, meaning, are they kind of all over the place, or are they able to stay fairly localized with one spot on the floor? Relax. There are other functional tests and measures that also might be warranted at this point. For example, lateral step down. This is a Reebok stepper. This is approximately 3 inches in height. We're going to set it down. Now, when I'm working with individuals, I oftentimes will demonstrate this assessment. And so I'm going to have my patient slide off to the side for just a moment. And here's why. Most of the time when individuals do a lateral step down, it looks something like this. And so you'll see a skewing of the pelvis. When we look at a lateral step down, we really want that individual to keep a neutral pelvis, a neutral alignment, allow the knee to bend, just kiss the floor and come right back up. That would be completed for 3 repetitions and back up, and then they would switch sides. Now, you can also play with height on this and adjust height accordingly, but recognize one of the biggest limitations to this test is the degree of ankle dorsiflexion that the individual has or does not have. And as you sequentially increase the height of the step, if they're lacking in ankle dorsiflexion, it will become an increasingly more challenging test for them to execute. So let's go ahead and have our patient step up onto the step. We're going to have them go hands on hips, keeping the pelvis square and level. Pull the toes back just a little bit for us. You're going to come down, just kiss your heel to the ground and immediately come back up. As we do this, we can visualize things such as dynamic knee valgus, an eccentric loading pattern through the lower extremity, the degree of closed kinetic chain stance stability, dorsiflexion, postural sway. There's all kinds of information we can get from just one assessment. And then we're going to have them switch sides. As we do with most of our tests, we're always comparing side to side. Typically, there's a side that the individual is complaining of an increase in symptoms upon, and so that we often will reference as the involved side. That's going to be compared to our uninvolved side. And so the lateral step down is a really, really potent functional test that gives us a lot of information about multiple systems and domains of our lower extremity. From here, we can ask our patient to relax. There are some other functional tests that we may consider. For example, we may look at stair ambulation. We may look at ambulation over and through a threshold or a doorway. We may look at assistive device use. But at this point, we're going to transition now to a seated portion of our screening exam. Once our individual sits down, our screening exam can continue, and the emphasis here is on screening. We're looking to do these tests fairly quickly and look to see if this individual needs further investigation into any area. So we're not going to be completing a complete formalized assessment of each area, but more or less gaining a snapshot or a window into the abilities and the functional abilities that the individual has. So we're going to ask our patient to slide back a little bit on the table. We're going to bring the table up. We're going to look at some active range of motion to begin with. And so what we'll ask the individual to do is to complete these bilaterally. And so we're going to ask them to pull their toes up towards the ceiling, point their toes down, good. Bring their toes in, and then point their toes out. Perfect. Go ahead and extend both knees for us as far out as you can. Good. And then flex them back underneath you slowly. Don't hit the table with your heels. Good. And then come back out. Go ahead and bring this knee up towards the ceiling as high as you can. Come back down. Switch to the other side. Good. Come back down. Excellent. I'm going to hold this here. The motion I want you to complete is to kick your leg out to the side as far as you can. Good. And then come back in. Same thing on the other side. Good. And come back in. Now you're going to do just the opposite. Bring this leg behind you just a little bit. Perfect. Try to bring this foot over this direction as far as you can. Good. And back down. Switch. Bring this leg back. And now bring this foot towards me as far as you can. Excellent. And back down. Very good. And relax. Try to bring your knees together as far as you can. Good. And now out as far as you can. Excellent. So there we have a very kind of quick down and dirty assessment. Ankle plantar flexion, dorsiflexion, functional inversion, eversion, knee extension, flexion, as well as hip flexion, adduction and abduction, and internal and external rotation. Are we missing a few? Yes. But that at least gives us a good window into whether or not there's any symptoms that are being provoked, or if there's any limitations or restrictions that we need to be aware of. While the individual is still in a standing position, is a great time to potentially execute manual muscle tests and or additional neuro screening, such as a sensation or peripheral dermatome assessment. You may choose to assess reflexes with a quick reflex hammer. Very quickly, you could look at S1-2, L3-4 on both sides. What that might look like is this, nice and relaxed. Good, and nice and relaxed. 2 to 3 quick taps per side. We can move to that other side. And if you get a blunted response or we're unable to elicit, that's okay. It may be user error, or it may just be an individual that's hyperreflexive. If we find the exact same result on both sides, it's likely that the individual is hyperreflexive. We may look at some other areas that are a little bit easier to elicit. Additionally, there may be 1 or 2 other areas that we may look at, such as protective sensation, if the individual has diabetes, or other tests and measures. At this point, though, we're ready for our individual to lie in a supine position. So we're going to ask him to lie down on his back. And we're going to now look at several tests and measures that corroborate what we just looked at in terms of active range of motion. And it can be done fairly quickly, so long as we're not finding any restrictions or areas for further consideration. First thing we look at is straight leg raise. Be careful with this, not to go too far. Oftentimes it's a good idea to do this actively before passively. You can increase dorsiflexion, hip internal rotation, or adduction if you want to also look at any neural tension. Additionally, if you're concerned about hamstring length, bringing them up to 90, and then looking for that end range, soft tissue stretch, you can then take your measurement here for a 90-90 hamstring length assessment. We look at hip flexion, internal rotation, external rotation, knee flexion, knee extension end range. Dorsiflexion, knee extended, we'll look at momentarily in a knee flex position, as well as plantar flexion, and then also the ability of the digits or the phalanges to move. And we look at inversion as well as eversion. This would be accomplished on both sides. We would complete this all on the right side as well. Straight leg raise is greater than 70 degrees. Again, we could also assess neural tension at this point. We now can perform an assessment of hamstring length. Hip flexion. Should be noted when you're assessing hip flexion, you're also looking for the cleanliness of that. Meaning, as they go into hip flexion, do they deviate out because of perhaps a cam or pincer type impingement? Or do they deviate in? Or is it clean, meaning straight sagittal? Looking at internal, external rotation. Make sure you get to end range. Knee flexion. Knee extension. Ankle dorsiflexion. Plantar flexion. Inversion. And eversion. Now with all of those, if you find something that requires an objective assessment, don't hesitate to grab your goniometer and gain an objective measure of those. From this point, we're going to ask our patient to go into a prone position, so to come onto their stomach. And there's a few other measures that we can also assess in this position. For example, we can ask them to bring their knees together. And now we can look at a measure of hip internal rotation. This is a nice measure to view symmetry from kind of an axial direction through the femur. Additionally, we can look at degrees of hip extension in this position. As well as now with the hip in a neutral position, degrees of quad length, or what we may say muscle length tension. Same thing can be performed on this side. This would be an Eli's test, or a prone knee bend if we're looking at neural tension. And again, we can look at hip extension both with the knee bent, or we can also look at it with the knee extended. Additionally, we noted that the knee was extended with dorsiflexion. We now need to look at that with the knee flexed, as the triceps sura is a two-joint muscle. When we flex the knee to this position, we now prioritize the soleus in terms of range of motion. And so we can look at placing our hands on the plantar aspect of the foot and assessing dorsiflexion. If we still find a restriction, oftentimes that individual is going to find a little bit more dorsiflexion in externally rotated or external kind of torsion position of the tibia. And so that oftentimes is where individuals go naturally to find just a little bit more clearance through that anterior portion of the talocrural joint. So assess both for quality as well as reproduction of signs and symptoms. Same can be done on our opposite limb. At this point, there's obviously other things that we could look at that we haven't yet assessed. Go ahead and sit on up. Things such as valgus and varus stress tests, things such as provocation and special tests, which will come in future videos. Things like swelling in that medial compartment of the knee using a fluid shift or stroke test. And so by no means is this a comprehensive assessment, but hopefully this gives you a window into a fairly quick and timely functional screen of the lower extremity, looking at a number of functional tests of ADL and mobility performance, as well as some range of motion, some neuro, and other tests that can be used to screen increasing the likelihood or decreasing the likelihood that those are contributing factors to the pathology that you're assessing. Have a go with these and other skills, integrate them with a peer or colleague, and let me know if there's any questions.
Conclusion. The lower extremity functional examination is a reliable tool to identify biomechanics in a population of female athletes. It had established moderate to good inter-assay reliability, which is similar to the result of other functional tests. The advantage of this new screening tool instrument is that it can be performed quickly, used in a variety of settings, and requires no additional equipment or preparation.